Our next presentation is on cardiorenal syndrome, what is new. May I have the pleasure of inviting for the next 11 minutes Dr. R. Kura. He is the head of the Regional Physician Specialist Nephrology at Poplar Bluff in Missouri, United States of America. He also is the adjunct assistant professor of medicine at the St. Louis University School of Medicine at Missouri. Dr. Kura.
Esteemed chairpersons, ladies and gentlemen, I want to shout my thanks out loud to Dr. H.K. Chopra, who's not here, Dr. H.K. Reddy, who's mainly responsible for me to come here, Dr. Satish Gupta, and the organization committee. I want everyone to know and hear how much I appreciate being here, for it not only has helped me learn about scientific sessions here, but enlighten me about my inner self. I can take home with me a much invigorated doctor, a better person with abilities to solve greater problems with ease. Having said that, I'll be moving on with a case report. I have a 66-year-old male with dyspnea and a past medical history significant for hypertension, diabetes, coronary artery disease with a stent placed in the left anterior descending artery with no other lesions. He has a history of left ventricle hypertrophy based on an echocardiogram which was done about a year ago. He comes under CKD stage 3 with a baseline creatinine roughly around 1.4. His medications at home included lisinopril, metformin, glucotrol, metoprolol, which is beta blocker, and aspirin. And his symptoms at the time of presentation were shortness of breath, which was progressive over the past 3 weeks, gradually from a point where he was able to walk 18 holes of golf to a current state where he cannot even talk without breaking the sentence. His signs included blood pressure of 150/90, heart rate of 88, bilateral rails, JVP of 12, and 1+ ankle edema. Laboratory data showed more or less everything within normal limits except for creatinine, which was 1.8 from a baseline of 1.4. The echocardiogram from recent studies showed EF of 40%, left ventricular hypertrophy, and a mild diastolic dysfunction of the heart. ECG was pretty much normal, other than left ventricular hypertrophy. Chest X-ray showed cardiomegaly with interstitial edema. Estimated GFR, based upon the latest lab results, was about 38 ml per minute, from a baseline of about 51 ml per minute. So the diagnosis in this patient is cardiorenal syndrome. So what exactly is that? It's a condition characterized by kidney failure or heart failure. The failing organ precipitates failure in the other organ. The bidirectional interaction of these organs can create a nexus or deterioration of both hand in hand. So what exactly do we know at this point about cardiorenal syndrome? We know it's very common. Failure to achieve decongestion of this situation leads to poor long-term outcomes, progressive heart failure, and ventricular dysfunction. And chronic kidney disease increases risk of death. Patients with chronic kidney disease have an increased risk of both atherosclerotic cardiovascular disease and congestive heart failure. And CAD is responsible for approximately 50% of deaths in patients with CKD. There's a Kaplan-Meier curve here showing a worsening renal function in setting of complete decongestion with increased risk for death. The mortality risk increased progressively with the degree of worsening renal function. The respective odds ratios were about 1.03 when the serum creatinine rose by 0.2 to 0.3 milligrams per deciliter, or the GFR went down by 5 to 10 ml per minute. The odds ratio went up by 1.48 when the serum creatinine went up by 0.3 to 0.5. And the odds ratio was about 3 when the GFR declined by 11 to 15 ml per minute. So, cardiorenal syndrome, in this particular situation, the heart failure hospitalizations have been rising steadily and constitute a major health care and financial burden. Patients hospitalized in acute decompensated state have 1-year mortality of approximately 50% and long-term mortality which has not been yet studied. Well, let's get on to the classification of cardiorenal syndrome. There are basically 5 types. The first type is acute worsening of the cardiac function leading to the kidney injury. Well, the cardiac injury could be of multifold, comprising of acute decompensation, any particular reason, flash pulmonary edema or due to ischemic insult, or a coronary angiogram, or a cardiac surgery, which leads to decreased cardiac output, decreased perfusion of the kidney, and leading to a prerenal situation. Exogenous factors by the cardiologists, including contrast nephropathy, overutilization of ACE inhibitors in the presence of diuretics leading to hypoperfusion of the kidneys. Humoral mediated damage, basically involving renin, angiotensin-aldosterone system, which causes increased sodium water absorption and in turn causes increased congestive heart failure. Hormonal factors and immune-mediated damage as well. Well, these causes from the heart can cause acute renal injury by hypoperfusion, apoptosis, decreased oxygen delivery to the kidney, and resistance to ANP. Well, the way we look at it is by predominantly creatinine, although some centers have started looking at NGAL, which is a better marker for cardiorenal syndrome. Moving on to the type 2, where chronic abnormalities of the heart lead to kidney injuries. Basically, the way it goes is if somebody is having an ongoing congestive heart failure, there's increased susceptibility to insults from exacerbations of congestive heart failure, which result in insults to the kidney. And the patient who are already having a CKD stage 2 or 3 easily jump onto 3 or 4 with progressive chronic kidney disease going into end-stage renal disease. And this in turn starts a whirlpool where the kidney starts having developing anemia due to lack of erythropoietin stimulating hormone, leading to further cardiac failure because of high output. The third type is acute worsening of the kidney. When we turn the plate around, well, acute worsening of the kidney function leading to the heart injury now. The previous 2 were from the heart to the kidney, now it's from the kidney to the heart. So any abrupt or primary worsening of the kidney function, for example, a renal ischemia or glomerulonephritis, can cause cardiac dysfunction, which may manifest as cardiac failure. So this is a figure or a slide of what I've just told. So acute kidney injury because of any particular incidents leading to sympathetic activation, renin, angiotensin, aldosterone system activation, hypertension, increased sodium water retention and absorption, causing acute dysfunction of the heart and exacerbation of CHF. And the fourth kind is chronic kidney disease leading to heart injury disease due to dysfunction. So somebody who is going on to dialysis, just before dialysis, something like a CKD stage 4, they tend to have chronic anemia, cardiac dysfunction, which could be a manifestation of coronary disease because of increased calcium phosphorus imbalance leading to coronary arterial disease, more MIs or heart failure, arrhythmias, drug toxicity because of retention of drugs in the body. So this is type 4. And the type 5 is any systemic condition in the body leading to simultaneous injury of either the heart or the kidney. The systemic diseases here contribute mainly diabetes, which is the leading cause. Next comes amyloidosis, vasculitis, sepsis, collagen vascular disease. All of these act through, again, sympathetic reticular system, sympathetic RAS, renin angiotensin aldosterone system. So pathophysiology of cardiorenal syndrome involves volume overload itself, number one, which increases the renal venous afterload and consequently impedes forward renal flow. That's the first mechanism. Basically, there's congestion on the renal venous side. The second is diuresis in pulse mode. So we give, say, furosemide about 160 milligrams. All of a sudden, the patient starts to pee about 2 liters of fluid in the next 2 hours, which transiently induces a pre-renal situation. And this situation might not be just enough for the kidney to handle. There's a transient bump in the creatinine, which should not be, an alarming situation, which should be taken with a pinch of salt, which is okay for that particular situation. The third situation or third condition for cardiorenal syndrome is intra-abdominal pressure, secondary to ascites and visceral edema. Let me jump here. Going to the inflammation in CRS is of two kinds, immune and neurohormonal. I'm not going to, basically reticular renin angiotensin system causes fibrosis of the left ventricle, causing diastolic dysfunction of the heart. The interleukins, TNF alpha and oxidation radicals cause end organ damage. Going on to the common clinical features of fluid overload. Dyspnea and exertional orthopnea and edema. These are the predominant signs and symptoms seen in patients with cardiorenal syndrome. The treatment is diuretics, which is a mainstay. No clear evidence has been shown of improved long-term mortality. Well, some of the studies which have done showed that hemoconcentration is the best way to assess mortality and improvement in the kidney and the heart function. And two trials, ESCAPE trial, which is basically a pulmonary artery catheterization effectiveness trial, showed hemoconcentration was strongly associated with worsening renal function. However, that was just transient, and this significantly improved 180-day mortality rate. Similarly, the Everest trial was another trial which was done with a vasopressin antagonism, which showed similar results. Taking fluid off improves the long-term mortality. The other treatment strategies include inotropes and ultrafiltration. We just talked about loop diuretics. I would prefer a continuous drip instead of a bolus. And inotropes are predominantly useful in wet and cold heart failures where there's a lot of volume in the legs. Patients have edema all over the body, more or less like anasarca. It is not as essentially beneficial in patients who do not have edema or somebody who has diastolic dysfunction of the heart. It is more beneficial in systolic dysfunction of the heart. There's a trial, which is a ADHE trial, which showed furosemide in combination with dopamine at 5 was as good as a dose of furosemide going at 20 milligrams per hour. And probably because of dopamine dosage at 2 to 5 mics, which has shown, or 2 to 10 mics, which has already shown that they have a renal dose of causing vasodilation. The next step is removal by RRT, which is renal replacement therapy, which we use most often in the United States for acute decompensation and is very effective, better than furosemide or Lasix. And we have never tried PD due to the risk of infections. but it can be used in situations with help of nephrologists, although it is laborious due to possible complications from infections. There's also lately left ventricular assist device implantation, and this has shown significant improvements in serum creatinine, although long-term studies have not shown any improvement in mortality risks and benefits. Well, that's about it. Any questions?
Thank you. So we will take.
What are the uses of NGAL?
NGAL is a gelatinase marker which is being used very rarely in the United States because of the expenses. Creatinine is much cheaper. Now, somebody who's got a creatinine of 1.4, and I've started him on Lasix, about 40 or 80 milligrams, whatever it is, pulse dose. The creatinine next day might still be 1.4 even though the patient has diuresed quite a bit. However, NGAL has shown that at the time of discharge, the patients who have increased NGAL have more readmissions to the hospital. That's the only study we have done so far. And NGAL is a better marker in the long term for readmissions and progression of kidney disease in the light of congestive heart failure.
What is the prevalence or the incidence of the disease entity in states or in India, if you have the statistics?
By statistics, you said, sir?
Incidence or prevalence of this entity in United States?
It is very much underdiagnosed in United States as well. I'm not sure about India, but definitely in the United States. The reason being, patients with chronic kidney disease inevitably have shortness of breath, left ventricular hypertrophy because of chronic hypertension. We as physicians tend to treat it more with vasodilators than diuretics, and I would prefer diuretics. Even though they do not act very well in chronic kidney disease patients, I would go up on the dosage. 50% of chronic kidney disease patients do have cardiorenal syndrome. I would put it that way. I'm not sure of about how much of congestive heart failure patients have cardiorenal syndrome, but definitely from renal standpoint, I would say 50% of patients do have cardiorenal syndrome.
Sir, as the Indian scenario goes, we have learned Indian physicians here. Tropical climate, use diuretics, loop diuretics, patient comes with hyponatremia.
Correct.
We have a lot of problems. We have more of diabetes, metabolic syndrome, all these cardiorenal syndrome. As we understand, as basic physicians, Indian physicians it's a diffuse entity. It's a very diffuse entity. No creatinine level or no GFR level can be fixed. If the patient has old diabetes, some degree of renal dysfunction, he has nephropathy, and echo is also very difficult to get it done, and all these things they combine together, and we feel that okay, all these constitute a cardiorenal syndrome in the Indian scenario. What's your opinion, sir?
Well, to come up with the cardiorenal syndrome as one of the diagnoses, you first of all have to have a definitive diagnosis of either of one for sure. Either the patient has kidney problem or definitely has a heart problem. If the patient has a heart problem, in the light of that, if the patient develops kidney problem, it could be two scenarios. It could be either because the patient's heart is really affecting the kidney, or if the patient is pre-renal because of the environment around. I mean, considering the temperature, the weather, and the amount of water he or she drinks, and eliminate that first, and then come down. I would ask the patient to drink about 6 to 7 liters of water, see how he does, repeat the blood test again, and if the patient still has decompensated kidney failure, then I would go with the diagnosis of congestive heart failure, cardiorenal syndrome at that point. Otherwise, I would first eliminate all the other etiologies first, and they are simple, it's not that difficult. I know it's very difficult to get all the tests done, but drinking water is easy. I would ask all my patients to drink about 4 to 5 liters at least per day, and then get on with repeat tests, and then evaluate these ones with the previous ones. Hope I answered the question.
Okay, thank you, Dr. Kura.